Are you going up? Okay. Oh, yeah, clicker.
We got power? Yeah. So thank you, Chad. One of the things we do as a board is to try to look at these topics every year and say, gosh, there's a few folks that have arrived in town, new physicians in town. It's a good opportunity for you to get a chance to meet them, and this is one of those opportunities. So Mike just arrived last year, has been less than a year here in town. He's actually a California native, or Colorado native as best I can tell, attended the University of Colorado in Boulder and for undergraduate, and then went to medical school in Denver as well. Did an internal medicine residency in Denver, and then for some reason went to South Dakota for about a year or so. Apparently got inspired to go into cardiology, headed south to Houston, did 3 years of his cardiology fellowship, and then, as you know, electrophysiology is kind of the rising star of the cardiologist. So he did a year of fellowship in electrophysiology, finishing in 2010, and then arrived here in Ogden in July of 2010 and has been here since then. So I'd like to introduce Dr. Mike Eifling.
California, easy there. Colorado. There it is. Thank you so much. Thank you, Heather, again, for the invitation to speak today. They asked me to talk a little bit about the management of electrical storm. And, you know, throughout training and throughout practice, you run into these patients that come in with recurrent ventricular arrhythmias. And you shock them, you give them drugs, and the Vt, the ventricular tachycardia, comes back. And they may have recurrent episodes. And this is particularly distressing not only for the patient, but I think doctors and nurses as well. These situations demand a lot of us. Sometimes you can feel fairly helpless because these ventricular arrhythmias tend to be recurrent. I've had a particular interest in VT storm and wanted to share with you not only some, I think, review some of the changes that have been made to the Acls guidelines last year, which I think are relevant, but also a few tricks in the bag that I think maybe aren't advertised quite as often that I have found particularly helpful. So this is a patient that we recently saw, 71-year-old male, has multiple prior myocardial infarctions. His EF is severely depressed, less than 20%. And he's brought to the emergency department for what was described by bystanders as a seizure, and he has an implantable cardiac defibrillator. He received in quick succession 6 ICD shocks. While he was in the emergency department, he was noted to have a wide complex tachycardia, and he gets 5 more shocks. He did not have any history of syncope, palpitations, or chest pain. He did not have any active heart failure symptoms. And his ICD had been recently interrogated and showed normal lead function. The impedance, the sensing, all the thresholds looked just fine. He did have a history of seizures, but he also had a history of bypass twice in 84 and 97. He had stable class 3 heart failure, had a history of non-sustained VT. This was the first time he had ever had ICD shocks. He originally had a pacemaker placed for AFib and sick sinus syndrome, but this was upgraded to a cardiac resynchronization device that was able to pace from both the right ventricle and the left ventricle. You can see here he was on good medical therapy on a beta blocker, ACE inhibitor, spironolactone, and aldactone. On exam, his heart rate was 165 beats per minute. He didn't have any obvious signs of active heart failure. He had a soft systolic murmur. His troponin was slightly elevated, 0.82. And a recent echo, we knew, showed his ejection fraction was 20%, a very dilated LV. He had had an old inferior wall MI, and that was evidenced by inferior wall hypokinesis with an inferior wall aneurysm, and he had moderate mitral regurgitation. So back to the bedside. This is his EKG, and this was not an Ogden case. This was from down in Houston right before I left. You can see someone has written on here this age-old debate, VT versus SVT with aberrancy, right? Probably SVT with aberrancy. And so when I saw this, it just reminded me that one of the most important things you can do in VT storm is to diagnose VT correctly. And in this, it can be hard, right? I spend a lot of my time sort of pontificating about, oh, well, this wave and that wave. The bottom line in a patient like this, though, is if you know someone has underlying structural heart disease, and if you know that their EF is less than 20 and they've had prior myocardial infarctions, bet on VT every single time. Just turn off the brain and just bet on VT. Now, there are some things here that point towards ventricular tachycardia. If it's SVT with aberrancy, we're saying that it's negative in V1, so we're calling it a left bundle branch block. And if it's SVT with aberrancy, it ought to be a very typical left bundle, right? And you can see here there's this transition between negative, positive, negative. That's a weird axis change between V1, V2, V3. That's not really typical for a left bundle. We always look for AV dissociation. I don't know about you, but it's hard to find, and I can't find any AV dissociation in this one. We know he had an inferior wall MI, and what's interesting is that if this was in sinus rhythm, you'd say, well, there's Q waves here, right? And it turns out that that works for ventricular tachycardia as well. If you have an old inferior wall MI, the VT will often exit from that inferior wall MI and give you a pattern that looks like that. And then furthermore, as far as left bundle, we don't see the typical large R waves out here in V6. And so the way I approach VT versus SVT with aberrancy is I just memorize what a typical left bundle looks like. I memorize what a typical right bundle looks like. And if it doesn't look like that, it's VT. So probably not VT, or SVT with aberrancy in this case. Again, just to reiterate, any unknown wide complex rhythm should be presumed to be VT. And if you do that, we know that in 80% of all patients with wide complex tachycardia and 95% of patients with a prior MI, you're going to be right that it's VT. That's particularly important because treating VT as SVT, beta blockers or calcium channel blockers, can precipitate cardiac arrest. Versus if you say, well, this is probably VT, electricity works for everything, right? For both SVT and for VT. So that's just a quick little reminder there of something that I think is very important. So this patient received IV amiodarone, continued to have breakthrough runs of sustained VT. This was hemodynamically stable. The patient got lidocaine, several boluses. Unfortunately, with his history of seizures and this catecholamine surge that he had from his VT, this resulted in 2 more seizures. His VT then became unstable. He got multiple more ICD shocks and had a cardiac arrest. So there have been some changes to our BLS guidelines now that he's in cardiac arrest. What we know is that most victims of out-of-hospital cardiac arrest do not survive, only about 5%. And part of the reason for that is that they don't receive any CPR whatsoever, and that the defibrillation is delayed. And so the survival rates are abysmal. So the American Heart Association, and they have changed the emphasis to encourage people to perform adequate CPR. And the age-old ABC that we all learned, airway, breathing, circulation, well, now they've reversed this, and now it's not ABC, it's CAB, and you're supposed to start with compressions, then airway, then breathing. They want us to begin with 30 compressions rather than 2 breaths. They feel like people waste a lot of time checking for pulses and look, listen, feel, and the whole time the patient's pulseless. And really what they need at that point is cardiac output. So you're supposed to begin with 30 compressions. They want us to be fast. They say push deep and push hard. At least 100 a minute and a depth of at least 2 inches. Allow the chest to recoil after every single compression. They want to minimize any interruptions in compression. That's true if you're out in the field or if you're in the emergency department or the ICU. So we have a tendency as docs to focus on intubation and drugs and other interventions. And they don't want, those are important, but they don't want those to get into the way of effective CPR. Furthermore, for the untrained person in the field, if they call 911, it's acceptable to tell them to just do compressions only and not worry about ventilation. They did update the airway management. As I mentioned, no more look, listen, feel. Just start CPR. Avoid excessive ventilation. There's a heavy emphasis on using end-tidal CO2 to not only confirm that your airway is in the proper location, but to monitor the effectiveness of CPR, with the thought that if you are getting adequate cardiac return back to the lungs, that you should be exhaling a fair amount of CO2. So if your end-tidal CO2 is less than 10, then you should improve your quality of your CPR. LMAs and alternative ways to manage the airway instead of endotracheal intubation are acceptable, and the routine use of cricoid pressure during intubation, as mentioned, is no longer being recommended. As far as updated electrical therapy in these guidelines, the one shock used to be shock, shock, shock. Now you're supposed to give one shock. That was not changed. Increased shocks in a stepwise fashion, which means if you're using a biphasic defibrillator, which most of them are now, you can increase from 150 to 200 or whatever that manufacturer's number of joules is. And interestingly, pacing is no longer recommended for asystole, which is a good recommendation because it doesn't work. Regarding arrhythmia management, how many times have you given atropine to someone with asystole and they just magically develop a rhythm again, right? Again, they finally updated this. Asystole does not respond to atropine, and so it has been removed from the guidelines. Atropine is still in the bradycardia guidelines, however. And interestingly, whereas I told you in the beginning, if you have an undifferentiated wide complex tachycardia, to assume that this is VT, the ACLS guidelines have said, well, if it's wide, and if it's perfectly regular, and if it's perfectly monomorphic, meaning every complex looks exactly the same, it's okay to give adenosine in that setting. Now, why do they say a regular monomorphic tachycardia? Well, that's because atrial fibrillation in the setting of WPW will also be a wide complex tachycardia, but it's going to be monomorphic because some of the electricity is going to go down the pathway, some is going to go down the AV node, and so the EKG QRS complex are constantly varying, not only in terms they're irregular because it's AFib, but also their morphology will change. Giving adenosine to a patient with AFib and WPW is contraindicated. So this is one recommendation. Again, if it's a wide complex tachycardia and that patient has a history of coronary artery disease or heart failure, bet on VT and you keep the adenosine in the drawer. For patients who have bradycardia, IV chronotropic agents such as isoprel or dopamine are equally effective as external pacing, which it can be difficult to actually capture the heart sometimes with external pacing. Lidocaine over the years has been de-emphasized, which is a big change for many of us because it used to be the go-to drug for VT. And bicarb is no longer part of the ACLS protocol. So in a nutshell, less emphasis on advanced airway central lines and drugs because they interrupt CPR. Post-arrest use of hypothermia is encouraged now. And there were a few specific circumstances that they felt were problematic. So a patient who has, don't confuse hypertensive emergency with mental status changes with a stroke. So, i.e., avoid giving thrombolytics like TPA in a confused patient whose blood pressure is 200 over 100 till you actually bring that blood pressure down. Because, again, giving those thrombolytics can be disastrous. All right, back to VT storm. So what is the definition? Well, electrical storm is defined as 3 or more episodes of ventricular tachycardia or ventricular fibrillation, or more than 3 appropriate ICD shocks in a 24-hour period. In electrical storm, about 90% of the time, the arrhythmia is as it is in this patient, ventricular tachycardia. Now, the etiology of all these patients have underlying structural heart disease for the most part, so they're predisposed to arrhythmias. But oftentimes there's a trigger, such as acute ischemia, heart failure, hypokalemia, infection or fever. But in about a third of cases, we don't ever really identify why they had this exacerbation of their VT. It is important to recognize that these patients are very anxious. This guy has now had 11 ICD shocks before he even got to the emergency department. And so his catecholamine levels are sky high. The catecholamine levels tend to provoke more VT, which provokes more shocks, which provokes more arrhythmias. And so the high levels of catecholamines are something that are important to address. And I have one slide on that just to emphasize that point. So when I do see VT at the bedside, how do I approach this? Well, it depends on what I see. In this patient, monomorphic Vt is a reentrant circuit through a scar, like a dog chasing its tail. And it's usually an old infarct-mediated reentry, right? That's different than if I see someone with polymorphic Vt. So they have Vt, but it's changing. Torsades is the classic example of this. And so if I see polymorphic Vt, I then say, well, when they're in sinus rhythm, what is their QT interval? If they have a long QT interval and polymorphic ventricular tachycardia, you've made the diagnosis of torsades. And the treatment of torsades is pacing, isoprel, magnesium, all these things that we have learned. If you have polymorphic Vt with a normal QT interval, you should think ischemia. People who come in with acute MI rarely present with monomorphic Vt. It's usually this polymorphic Vt that's changing because they have ischemia that affects the whole ventricle, whereas monomorphic Vt due to structural heart disease is usually this, monomorphic Vt. And some patients who have ischemia also will just present with VF, just recurrent episodes of ventricular fibrillation. So if I'm at the bedside, I say, monomorphic Vt, this is an old scar. Polymorphic Vt or VF, I think this guy needs a heart cath, and I need to be giving beta blockers and things like that. If it is polymorphic Vt with a long QT interval, then that makes me think of torsades. And this is important because the treatment of all of these things are different depending on what the underlying cause is. ICD shocks. There are so many defibrillators out there now that you will not be able to avoid them. You will see people who come in with shocks. And so I will remind you that multiple ICD shocks are a medical emergency. ICDs do not prevent arrhythmias. They just deal with them when they happen. And whereas I mentioned your chances of surviving an out-of-hospital cardiac arrest are only 5%, if you have a defibrillator, the odds of surviving are 95%. So they work very, very well. However, shocks are poorly tolerated by patients, families, doctors, and the key to diagnosis is often in the clinical history. As you know, you can have malfunction of the lead or of the device, and they could get inappropriate shocks. Well, I asked the patient, if they were asymptomatic prior to their arrhythmia, that makes me think, well, maybe there's something wrong. Maybe this is AFib, or maybe there's some problem with the device. Is it positional? The patient lifts their arm and then they get a shock? Or does it suggest that they may be having a heart failure exacerbation or angina? Do they have multiple leads on the chest X-ray that might be banging together? And then do they have palpitations? Well, it doesn't really help because VT can give you palpitations, as can SVT or AFib. So as I mentioned, when I see a patient with shocks, I say it's one of three things. It's either appropriate, meaning they had a real rhythm like VT or VF that needed to be shocked. It's inappropriate, meaning it's SVT or it's AFib, which is rapidly conducted and meets the rate criteria that the ICD was told when you cross 150 beats per minute, shock. And AFib can sometimes go that fast. So if I saw AFib and someone was getting shocked multiple times, I would give them beta blockers to slow the rate down below that detection criteria. Or I might put a magnet over that ICD to tell it to suspend its detection. There are some patients, particularly those who have been shocked numerous times in the past, that will come in and tell you, look, man, I know I got a shock. And then we interrogate the device and nothing has happened. And this is a form of post-traumatic stress disorder. And those patients require reassurance. I'm very careful how I program my ICDs to avoid inappropriate shocks because sometimes patients can take a disease that's bad and you give them a therapy that can be worse. And so the programming of that ICD is very, very important to avoid inappropriate shocks. So I calm the patient, I give them sedation, I attach external defibrillation pads just in case the device doesn't work, and then I call the EP and I say, hey, you got to get down here and interrogate this thing, right? You can interrogate the device and get a wealth of information out of that device. It's important to know that when you put a magnet over an ICD, it doesn't affect the pacemaker function of that device, but it suspends detection. It's like putting a blindfold on the ICD and saying, don't look at what's happening. If they're having VT, that's a bad idea. If they're having SVT or AFib, or you think they have a fracture of their lead, if the device is shocking, but when you're looking at the monitor, you don't see VT, put a magnet on it, right? If they do develop VT, if you pull that magnet off, the device will immediately reinstitute therapy. You notice our patient had a little elevation in his troponin. That's common after multiple shocks, 0.8, 0.9 range. If you have troponins of, 6, 7, 8, 9, 10, that's not usually from shocks. That means that they actually have ischemia. And I've worried about this, contacting and touching the patient when they get shocked. Am I going to get shocked kind of thing? I was actually listening to a patient one time, and I was like, sir, take a deep breath. Sir, take a deep breath. Pow, got shocked. And I'm okay. So lidocaine, an oldie but a goodie, has a long history of easy administration. We know everything there is to know about the pharmacologic and adverse profiles of lidocaine. And lidocaine may be particularly effective in that patient that comes in with acute ST elevation, or it has active ischemia and that polymorphic Vt pattern we talked about. But there's no real evidence from any randomized controlled trials that lidocaine is better than any other drug, or placebo for that matter. And amiodarone has replaced lidocaine now as your go-to drug in this setting. Procainamide is a very good drug, and it is sort of having this reemergence of popularity, and I think it does work extremely well for monomorphic Vt. The problem with procainamide is you have to give it over 10 minutes or so, and all these patients get hypotensive. When you run in 250 milligrams or 500 milligrams of procainamide, they all tend to drop their pressure, and so that limits its use clinically. Amiodarone. Of the antiarrhythmic categories, class 1, class 2, class 3, class 4, amiodarone is promiscuous. It binds to everything. And it blocks acutely beta receptors, beta blocker, and it has calcium channel blocker effect as well. So it's sort of the shotgun approach to antiarrhythmics. It has a little bit of everything. It really doesn't affect the inotropic aspect of the heart in terms of contractility, so hypotension is not really all that common. And despite amiodarone prolonging the QT interval, the incidence of torsades is actually very low. It's the antiarrhythmic choice for electrical storm currently, and there are a few little minutia details where it may affect the defibrillation threshold of their device. That's more my problem than yours in terms of acute management. Amiodarone is a great drug. All right. Beta blockers, not in the ACLS guidelines. In fact, epinephrine is in the acute cardiac arrest situation. But as I told you, when patients have this catecholamine surge, there's this spiral that happens of more catecholamine response, more anxiety, VT gets worse, more shocks. And so if the patient's in cardiac arrest, epinephrine obviously is still necessary. But when the patient comes in and is having multiple runs of VT, just put this little trick in the back of your mind of either propranolol or metoprolol. I prefer propranolol because it blocks both the beta-1 and beta-2 receptors. A milligram of propranolol in some of these patients is just like magic, and it really will calm their VT down. Now, if they're in active heart failure, surprisingly, the beta blocker doesn't seem to exacerbate that very much, but you do obviously have to be careful with that. So beta blockers in the setting of acute VT storm, I think, are very helpful. This has been looked at in a trial where 49 patients had recurrent polymorphic VT and VF. So to get into this trial, how do you like this? You had to have more than 20 episodes in 24 hours of VT, or more than 4 episodes of VT every hour. These patients were quite sick. In group 1, they were treated with sympathetic blockade, mostly propranolol. The other group got lidocaine, procainamide, and a drug Bertilium, which is no longer available. And interestingly, the mortality at 7 days in those who had beta blockers was 22%, high, but not as high as if you had all those other class 1 agents, which was 82%. And overall mortality, this was measured a number of months later, those who had sympathetic blockade, they still had a 67% mortality, pointing to that VT storm is a bad thing to have. But the class 1 agents were 95%. And the patients who did the best got the combination of amiodarone and a beta blocker. And so this is my sort of initial combination when I see a patient that has recurrent VT storm. All right, I mentioned sedation. Anxiety, multiple cardioversions, increased catecholamines, and perpetuates arrhythmias. Sedation is important in all patients who have electrical storm. And if your patient has an ICD and they're getting shocked, amiodarone, beta blocker, a little Ativan, a little Versed, something short-acting, something to take the edge off for that patient will really be helpful. Benzodiazepines, propofol, general anesthesia, these are all very antiarrhythmic. And I have used multiple times where patients have just been refractory to everything. And I call one of my friends, the anesthesiologist, and I say, look, we need to bust out some halothane here and get this person on, get them intubated. And the arrhythmias just go away. And so, again, I think that points to this catecholamine sort of response. There are some other interesting things you can do where if patients can't be intubated, you can use thoracic spinal epidural anesthesia, which also blocks the sympathetic nerves that exit the thoracic spine, and this also has been used to treat refractory VT storm. Patients that are ischemic and those that are non-ischemic, an intra-aortic balloon pump is a very effective way to treat those patients. I've seen numerous people who post-bypass have a graft that goes down, and they respond dramatically to balloon pump. And finally, radiofrequency ablation. This is a particular interest of mine. This is a program that we are doing at McKay currently. And so this has been looked at in several clinical trials where patients have been taken sort of emergently to the EP lab, and we try to actually ablate that rhythm. These patients are very sick. It requires some pretty advanced technology in terms of mapping their VT circuit. But in this trial, electrical storm was suppressed in all patients, and over 22 months of follow-up, 92% were free from electrical storm. 66 were free from all episodes of VT. But it was important that you actually ablated their clinical VT. 10 of these 95 patients in this trial, at the end of their ablation, still had inducible VT, and 8 of those 10 came back with recurrent electrical storm, and 4 of them died despite ICD therapy. This can be a difficult ablation, and these patients are sick. But this is what happened with our patient. He continued to have runs of stable monomorphic Vt on IV amiodarone. Propranolol significantly reduced his Vt burden. Coronary angiography showed that his grafts were intact, and an EP study showed easily inducible clinical VT. So I made a 3D electroanatomical voltage map. So by putting a catheter inside the left ventricle and touching hundreds of spots throughout the ventricle to collect information on not only the voltage but also the geometry, and we found that what we knew, it confirmed that he had a large inferior wall scar. He had this VT, which was inducible, and I thought, well, that's not his VT I saw in the ER. That's odd. And some patients do have multiple VTs. But I terminated that, re-induced, and got his clinical VT. And what was interesting, and I put this in just to emphasize this point, is that VT in old scar is like a dog chasing its tail. And it can go clockwise or counterclockwise. And this is his scar. This is his left ventricle. Purple is normal voltage. And this is the heart kind of rolled over on the bottom side. This is all scar. So red means it's dead. And this is all wounded tissue that doesn't beat very well, but it can still conduct electricity, although slowly. So he had a VT circuit that was running through the middle of this scar, and sometimes it exited here and gave that VT. Sometimes it spun the other way around and exited here and gave that VT. And so interestingly, if you look at all these precordial leads, they're just mirror images of each other. And this reflects the fact that this channel of tissue that I then ablated through the middle here, this is where the initial line that we made, where the VT was coming through. So the patient was in VT. You drag a line through there, and this VT is using these wounded but still alive pieces of myocardium. And as you ablate the bridge that it's using to get through there, the VT terminates. And this patient actually did quite well. So in general, I wanted to just point out that electrical storm is common, and unknown wide complex tachycardia should presume to be VT in a patient who has underlying heart disease. The new guidelines recommend CPR and emphasize that. Patients with ICD shocks where the ICDs can present with multiple shocks, that IV amiodarone and beta blockers are really the cornerstone of your medical therapy. Sedation is important in these patients, and give me a call if someone has acute VT storm, because they may be a candidate to go to our lab for radiofrequency ablation. All right? Thank you. Do we have time for questions, or did I? Okay. Any thoughts? Yes, sir. Yes, sir.
Do you have to interrogate after that magnet's put on all the time? Do you have to bring in someone from the lab to look at that pacer after you have put that magnet on?
We never mind being called. If there's any issue whatsoever with the device, either with the company, myself, one of my nurses, we're always happy to come and look at that device. And I would say that if someone is having an issue, the only time that might not be true is in the operating room, because if someone goes to the OR for a surgery and they're going to have bovie, which could potentially interact, I think at that point it's fine to put a magnet on that. And in almost every ICD out there, there are some older ICDs that when you pull that magnet off, it can change some of the programming in that. Actually Friday, there were new guidelines that were just put out through the Heart Rhythm Society that speak to this regarding how do you manage patients when they go to the operating room. And to be honest with you, I haven't read those guidelines yet because they just came out. But in general, it's fine to have the magnet on and doesn't necessarily need to be interrogated afterwards.